So we shall now go on to our next speaker, Dr. Arivazhagan, a very eminent professor of neurosurgery in NIMHANS, Bangalore, with special interest in neuroendoscopy, neuro-oncology, functional neurosurgery. He would be speaking for the debate session, I Vouch for Shunting Procedures. We all look forward to some amazing insights to neuro-ophthalmic aspects of neurology from him. He is to be contested by another very prolific surgeon, Dr. Sachin Kedar, who would be talking on the safety and simplicity of optic nerve sheath decompression. And Dr. Sachin is a professor of the Department of Neurological Sciences, Ophthalmology and Visual Sciences, Program Director of the Residency Program of Neuro-Ophthalmology and Ocular Electrophysiology. So on to you, Dr. Arivazhagan.
Good evening. I'm just trying to share the screen. It's not... Yeah, good evening. Is my screen visible?
No.
Yes, it is.
Yes.
No.
Yeah, just a minute.
It was. Yes.
Yeah. Is it seen now?
Yes.
Yeah. Good evening, everyone. It's a privilege and honor to be invited into another society to share my thoughts, and I thank Dr. Murali to given this chance. And let me tell in a few minutes my understanding of this topic. I will be talking about the use of shunts in idiopathic intracranial hypertension. And this idiopathic intracranial hypertension diagnosis itself, as well as the pathophysiology, is not yet clear, though we know it for more than a century. Why it happens exactly is not clear. It may be either because of increased CSF production or reduced drainage, or it can sometimes be also postulated that because of increased venous pressure, venous sinus pressure, because of focal or diffuse venous sinus stenosis. And of course, we also know that the obesity and other inflammatory factors can contribute to the cause. And then various criteria have been devised. The latest one is 2013 modified Dandis criteria, wherein a patient should have a papilledema with normal neurological examination and normal neuroimaging with normal venogram, and lumbar puncture being more than 25 centimeters of water. So I'm going to talk. The topic given to me is shunt versus optic nerve sheath penetration, and I'm not going to be stupid to come into a ophthalmology conference to say that your procedure you do is not good. I don't look at it that way. Does it always have to be like this, one versus another, or both procedures can work symbiotically to give the best for the patient? So what is the evidence to choose between these two procedures? What do we have as of now? There are no randomized control trials. There are no prospective comparative data, no large-scale studies, and all the inference is from meta-analysis literature reviews of retrospective studies. So these are the four major papers that I could find to compare the outcomes of these two procedures in intracranial idiopathic hypertension. Most of them are meta-analysis and systematic literature review, and you can see two out of four are from the same group. So if you look at the data that's available to us, this is a paper in 2017, where they compared the outcomes of all the four procedures: optic nerve sheath penetration, lumbar peritoneal shunt, VP shunt, and Steiner stenting. If you look at the number of patients, they are fairly equal. And if you look at the outcome, the improvement in visual field and visual acuity is almost comparable to among the three. The headache improves better with shunting than with only optic nerve sheath penetration. And like you can see, but what's more important is to look at the complication. I'm sure my colleague Dr. Kedar is going to talk more on that. Yes, I agreed. Among the complications, optic nerve sheath penetration is obviously has less complication compared to the shunts. Compared to the shunts. If you look further into the complication, this slide would give you more detailed understanding. Most of the complications that happen with shunt are basically hardware related. These shunts are mechanical tubes. They can get blocked, they can get migrated, and they can also cause over drainage. And there are some incidents of infection, which is obviously there in any procedure. And this is the latest paper which came this month in 2021, which again has compared or studied all the major studies. And as you see, the headache improves better with shunting, visual field and visual acuity improvement is comparable across the 3 procedures. And if you look at the complications, the shunt has obviously a more severe complication. Here, the incidence of meningitis is taken as severe complication. Of course, when you deal with a procedure which enters subarachnoid space and CSF, and there's always a risk of infection, which is not there in optic nerve fenestration. Also, there's a 0.3% of mortality with shunts, and as what I said and what I saw in the papers, there's no documented mortality with optic nerve fenestration. But let's put this in perspective. These shunts are basically subcutaneous procedure. It's when you come to lumbopatellar shunt, is basically placing a catheter into the lumbar space. It's like doing a lumbar puncture and then tunneling the catheter subcutaneously and placing the petrol cavity. Ventricular petrol shunt in IH is slightly more difficult because there are the ventricles are slit-like in this IH, whereas in regular patients where we do for obstetric hydrocouplers, ventricles are dilated. And as of now, we have more better technology of programmable shunts, which can take care of this over drainage problems, and therefore that has become a less of a issue as far as complications or side effect of the shunts are concerned. So let us look at these 2 procedures in the perspective, what we see in the general practice. If you look at this paper, which has talked about the use of shunt versus optic nerve fenestration from 2012 to 2016, the large number of shunts have been done compared to optic nerve fenestrations. About 10,000 odd shunts compared to 300 fenestrations. And this is the consensus guidelines of management from UK, which has been critically reviewed by various societies of neurologists, ophthalmologists, and neurosurgeons. It says the best surgical procedure for visual loss as of now is CSF diversion. Of course, ONSF is performed more frequently, and it can be considered as other procedure. So there is no data of superiority of one over the other. Indications can be subject of symptom specific. It will definitely be influenced by local practice and expertise available. So, but if you look at the indication, the optic nerve sheath fenestration is preferred in patients who have got visual deterioration as the only symptom. And whereas if a patient has both headache and visual deterioration, then CSF diversion is preferred as a first procedure to do it. Venous sinus stenting is often considered where you can identify a focal stenosis and show a more than 8 millimeter mercury pressure difference. So to conclude, shunt is useful, and when indicated, I'm going to steal the tagline of the next talk, which is simpler and safer. I would say that shunt is simpler because every neurosurgeon can do the shunt procedure. It's one of the first procedure that a neurosurgical trainee learns and starts doing. It's typically technically simple, like doing a lumbar puncture, and then it's safe. I won't call it safer because the comparative risk of complications is more with the shunt, obviously, because of a hardware involvement, and it involves high rate of shunt revisions, but that's inherent to this procedure. And even if there's a shunt revision, it can be still safely performed. And with the programmable TCO-petrol and BP shunts, drainage can be controlled and over drainage can be avoided. And we know that how shunt works. It has a well-established mechanism of action by draining the CSF from the brain and reducing the intracranial pressure. Thank you.
On to you, Dr. Sachin. Wonderful talk.